Hey, hi everyone. It's Naomi Wolf. It's Naomi Wolf of Daily Clout, and I'm really thrilled and honored to be welcoming yet again one of the most distinguished commentators in this series, Dr. Andrew Bostom. He's an epidemiologist and academic internist at Brown University, and he's been incredibly insightful about the medical side as well as the public health side of this public health policy debacle. Welcome again, Dr. Boss.
Thanks again for talking with me, Naomi.
So I reached out because I saw that you were addressing three new subjects that are really serious, and I want to get into each of those in turn. And the first one is masking. What is it? What are some of the new things that you found about policies around masking, please?
Well, the issue came up actually yesterday during the weekly presser in Rhode Island, where a non-journalist, actually taking on the role of a real journalist, confronted the director of the Rhode Island Department of Health, Dr. Alexander Scott, over the issue of masking and when the mask mandate might be lifted in Rhode Island. And in layman's terms, he quickly reviewed what we've discussed actually last time about all the randomized controlled trial data being essentially uniformly negative when it comes to the issue of masking. But he also mentioned this interesting observational finding, which was that you could the state of Rhode Island. There was a national survey in the state of Rhode Island. It was a sample of 100 persons, random sample from each state, and they were asked about their masking habits.
Mm-hmm.
And the state of Rhode Island had the highest percentage, 96% of persons who responded, who said that they wear a mask, quote, every time they go out. And and that survey was published November 2nd. And as Pat Ford pointed out yesterday at the presser, that was just a couple of weeks before we experienced this enormous two-tiered spike in Rhode Island that lasted from mid-November till mid-January in terms of infections as recorded by the Department of Health. So he used both a quick reference to the randomized controlled trial data, and this observational data from Rhode Island to say, what gives? Because now the metrics in Rhode Island indisputably are very reassuring. We literally had 2 days in a row with no deaths.
Wow.
Recently. The hospitalizations and have plummeted by 80%. The infections, and I would like to elaborate a little bit on this. The infections have held constant for 6 weeks now at about 2% of the number of tests administered.
Right.
And one of the things that concerns me about this. Oh, I'm sorry. So before I step on the whole point. So after Pat laid this out for her, the facial expressions, I actually put up a video of it. The facial expressions of Dr. Alexander Scott, and then we're just negative, and she was masked and then unmasked. When she was masked, you could see the furrows in her brow. When she was unmasked, she just had this look of contempt, and she finally said to him, "Masks work. Next question." That was it. There was no attempted rebuttal of the evidence that he provided, as a layman, but very, very, I thought it was done well, concisely. That was it. Mask work. Next person. Cool. Yeah,
That's like Stalinist epidemiology.
Exactly.
Because I said so.
Stalinist, Lysenkoist, same era, Yeah, but the point was that we've ceded so much power to these public health officials, and yet we still don't expect any sort of polite, evidence-based discourse for them to. They don't have to engage in it. Masks work, end of discussion.
I mean, this is so much like what I'm experiencing with Massachusetts, where I reached out to an unnamed, local public health board and said, "Where is the science for masking?" And they said, the state hasn't given us any. The state health board hasn't given us any. And I keep calling the governor and saying, where's the science? And all I got was a response saying they wouldn't talk to me. That's extraordinary. And so as an epidemiologist, are you in a position to follow up with her and say, what is the response to this citizen of Rhode Island?
So I what I did is you know, mea culpa. I had actually spoken to this person because Pat Ford, who's I think he's the head of the Libertarian Party in Rhode Island, but he's not a journalist. But he's the only one who acts like a journalist at these presses. So we had a conversation before. I had thanked him for some previous questions he had asked, and the night before, so this was yesterday. So Wednesday evening, I had actually spoken to him and said, "Gee, you know, there's all this compelling data that masks really don't work, and maybe you could broach the subject because I don't understand how long they're going to keep the mask mandate going when all the indices, the objective indices in the state, look so good, look so reassuring to people that." You know, it's such a symbol of fear, really, Naomi. It's like a talisman of fear that let's liberate ourselves. And I also pointed out to Pat, and he didn't mention this, that in fact, I think the number's grown now, but it's 17 states that either had very weak mandates to begin with or had them and have now abandoned mask mandates. And all 17 of those states have lower per capita COVID-19 mortality than Rhode Island.
Wow.
You know, so I just said, you know, so I actually got on the air on a local radio station, WPRO, after the presser, and I was able to make all these points, you know, with a little more evidence, you know, hard evidence, and reviewing the clinical trials and things like that, and you know, so that was the way I responded to the situation. So, you know, I've written to all the public health officials in the state. They don't respond. They don't respond.
You with your distinctions. All right, so that's madness. Is there anything else you want to say about mask evidence, or is that the update for masks, this press?
Yeah, just the related issue of so they were concerned. It's kind of all ties together, Naomi. They were my state's, you know, a public health director was concerned about the variant, actually, right. Variant. Oh, okay, right. and this, as she put it, and it's true, this plateauing at about 2% positivity for the PCR, predominantly PCR testing, and there's a very, I don't know if this can contribute to the explanation. First of all, I do not believe that with something like COVID-19, you go for an eradication policy, a zero COVID policy. People are pushing that. Yeah, I just don't think it's rational. It's needed. But there is this phenomenon. There's the CDC tracks the 4 other common, excuse me, cold-causing coronaviruses.
Right.
One of which is really interesting because, you know, now that sophisticated genetic studies can be done long term, almost like genetic evolution studies can be done. It appears as if this coronavirus, which was OC43, that's the way a lot of them are coded, was probably the source of the Russian flu pandemic in 1889 to 1890, which was thought to be, as in the word flu, it was thought to be a flu. Right. It turns out that you know, genetic microbiologists have traced, just one second, have traced the origins of a coronavirus that it underwent what's called a zoonosis, so it goes from an animal species to a human species. It apparently crossed over from cows to humans.
Wow.
Just around when this outbreak broke, and they're now arguing. There's been a couple of papers about this. They're now arguing that that's a much more plausible explanation for this pandemic, which lasted several years, and interestingly targeted the elderly. And so now we know OC43 circulates as a seasonal coronavirus. It still can wreak some havoc if it gets into nursing homes. Right, but basically it's dealt with by the majority of the population as a cold. Well, it turns out CDC tracks this virus and 3 other related human cold-causing coronaviruses. We happen to be in the midst of a spike. And so knowing that, and knowing also that there's at least one, you know, when new assays come out, the labs and the good studies will do the new tests. So
Okay.
so when the PCR tests came
Mhm.
out for SARS-CoV-2 for COVID-19, there was a very good study done in Europe which sent all kinds of samples, including blanks, to
Mhm.
see how compatible the laboratory results would be for the different PCR platforms.
Mhm.
And one very clever thing they did is they spiked OC43 and another human cold-causing coronavirus, NL63, in a blank, which of course should have been 100% negative for SARS-CoV-2.
Right.
It was 3% positive.
Oh my God.
Yes, including
Oh my
including now
God.
some of it was indeterminate. Some it was so and so the actual false positives were about 1% or a half a percent. But when you get down to when you get down to very low actual prevalence of the virus, I mean the fact that we're having a seasonal spike in this coronavirus and there is this possibility of cross reactivity, that could be contributing to the sort of apparent stabilization of this rate beyond other methodologic
Right.
things.
So, so at this point, I try to like translate into super lay English.
Sure.
I think what you just said is this: there's some evidence emerging from some credible peer-reviewed sources or several papers that indicate that this is not a totally new novel coronavirus that emerged out of a lab in Wuhan for the first time in human history, but it actually appeared in the 1880s
Oh,
in
no,
Russia.
no, 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 no. No. I wasn't. I'm sorry. I'm sorry if I gave that impression. No, I wasn't saying that. It's just that there are. It's a coronavirus, and
Right.
there's a previous coronavirus now called OC43, which appears to have jumped from cows
Right.
back in the late 19th century, and a similar phenomenon may have happened with SARS-CoV-2.
Right.
But more importantly, they have enough in common that there could be some interference in testing,
Okay.
and
So
it turns out that right now
yeah.
there's 4 human coronaviruses that are seasonal cold-causing coronaviruses,
Okay.
and they happen to be going through an uptick now, a seasonal uptick,
Right.
and some of this, so when states are saying, but actually particularly in the Midwest, there's a big spike of these cold-causing coronaviruses in the
Right.
Midwest. Some of that, I'm not saying that it's uniformly contributing and it's all false positives, but it's got to be in the mix there when the assays have their limitations, when the tests have their limitations, and so
Okay, let me jump in and try to
sure,
say it correctly in English.
sure,
So what's happening is that this old cold virus that has been around human beings for 140 years is circulating again, which is how cold viruses work. And it's similar enough to SARS-CoV-2 that it's interfering with positive results in
it could be.
PCR tests. It could be.
Right.
And for the first time, you and I talked last time about how few double-blind controlled studies there were in this pandemic, but you're saying that a controlled study has found that it indicates a significant enough level of false positive to make it look like there's a spike or there's a problem with
It,
something.
it, it, it certainly could. It certainly could theoretically, on the basis of the initial rollout of these SARS-CoV-2 assays, where they were looking for problems like this, and lo and behold, they seem to have found some interference with at least 2 of these cold-causing coronaviruses. Now, some of the PCR platforms may be more specific and eliminate this. But this was a pretty comprehensive study that was published last June, I believe, and it raised some concerns. Now, the other issue that we dealt with directly, and I think I briefly mentioned last time, was with the way we interpret any PCR test for SARS-CoV-2, and since it's a test that literally tries to amplify specific genes in the virus. It's an RNA virus, so it's amplifying segments of the RNA. It's very much dependent on where you set the limit. In other words, how many amplifications
Right.
can you take it through?
This is the
And
cycle threshold question.
the whole issue of cycle thresholds, and so the CDC recommended, I guess, for sensitivity. not for specificity, but for sensitivity, so that you wouldn't miss cases, to take the samples through 40 cycles.
Right.
The problem with that, though, now that we have a big body of evidence where they look at the results of the PCR tests and they compare that to splitting the sample and literally trying to culture out the virus, which is very tedious. And obviously, you're not going to do that for the gazillions of tests that are going on. But what they found is that once you get above 30 cycle repetitions, so a cycle threshold above 30, it's very hard to show evidence of a virus that can be captured in culture and cultured out. And so it's problematic when the so-called positives shift into a range, as we found in Rhode Island, where the preponderance of the positives are at a cycle threshold above 30. But what's also reassuring, though, Naomi, is that when we looked at the first wave, and we had to go through, it's basically a FOIA request at the state level to get the lab to release this data. And when they finally did, in 5,000 tests, it was really beautiful. What we could show was that as the first wave, crashed and really came down to levels like it is now, actually, in my state, in Rhode Island, we found that the preponderance of tests that were quote unquote positive were occurring at above a cycle threshold of 30. And in other words, it had a very tight correlation with mortality dropping precipitously.
Oh my God. All right. So
and we published these findings at least as a preprint.
Okay, that's what I wanted to make sure to ask you about. So
I'd like to do that again right now, because I think that's where we are. And it's one of these indices which would say, okay, it's time to open. So something's still circulating, but probably, kids are getting it, healthy people are getting it. They're able to maintain a low viral load, because remember, Naomi, the idea is that if we're going to use the cycle thresholds at all, they're basically a surrogate for the amount of virus. So the higher the cycle threshold, if it means anything, the lower the amount of virus the person, is harboring.
All right, let me jump in there. This is one of the best public policy ideas I've heard in this whole debacle of the last year.
It's tragic too, though, Naomi, because as far as I can tell, virtually, certainly in my state and in most places, virtually all of the platforms doing this massive amount of PCR testing have the cycle threshold data for each test. Now, some of it, it's stored in a very sophisticated way, massive internal computer spreadsheets, Excel-like files you could imagine. And other places, it kind of ticks out like the old-fashioned ticker tape at the cash registers. So they'd have to do something more, more cumbersome to record it. But it's there by and large in the major platforms.
Let me really drill down into this for a minute. Speaking as a citizen, and less about the science. You've audited, which is huge. It's a hugely important thing to have done. Rhode Island's PCR test cycle,
at least through the Department of Health's own lab.
Understood.
Which is another problem, Naomi, because now it's farmed out massively.
And I had that same experience in New York State. The government. The actual hospitals wouldn't test me because I wasn't sick and had no symptoms, but CVS was happy to test me all I wanted. And I didn't know where my results were going or, who was.
Was it PCR testing in the case of CVS? Do you know? They didn't even tell you. Yeah.
Where's this going? I don't know. Who's going to look at the results? I don't know. Can I see the results? I don't, literally. And then I got nothing, no documentation at all.
We had one, besides the essentially equivalent of a FOIA request, we had one positive individual citizen anecdote, which is important. This was an adult correctional institution guard.
Yeah.
And he was told he tested positive. And he had minimal symptoms, but he was, isolated from his family and everything. And so he got in touch with me.
Yeah.
And eventually, through real perseverance, he got his cycle threshold. It took a couple of weeks. His cycle threshold was 34, which matched the very benign clinical presentation. Now, it's not a one-to-one correlation. It's not always going to match up, just like any other laboratory test. They can be helpful, but they're part of a whole picture.
Right.
So you can certainly find people that'll be basically asymptomatic, but have a very low cycle threshold. So
right. And
as an individual.
Right. So good for him jumping in other sources. And you have also told me that, and you were sort of telling me this early in this interview, that you can have a positive test with another kind of cold or coronavirus. So there are a couple of things that'll could distort the test. But let me get back to the public,
Sure.
because that's what really is so important about you and what you did in this interview. You are
just one other thing that I don't want to forget about, because you're talking about public policy. I want to get back after you finish. I want to get back to what's being done with the whole issue of cycle thresholds in India. Okay.
We will, I promise, but I need to spell this out. Your proposal that all of the cycle thresholds and the data are there, they may be cumbersome, but if you're taking publicly important data, it's up to you as a lab to make it publicly available. It's up to you as a government to, take those printouts and turn them into, publicly available data sets. You want to have a policy where Rhode Island makes transparent and available its data sets for PCR cycle threshold.
Every day on the dashboard.
And there's
dashboard. So Naomi, it would be ideally. I'm sorry, go ahead.
Going to finish. I'm going to do it. So having, running a data dashboard, I know that this is possible and it's easy to update this every single day. There is no reason not to. And what I'm saying, I'm building on what you're saying. And what I'm saying is there needs to be federal legislation, as well as every single state doing the same thing, making those cycle thresholds publicly available and making it possible digitally so that everyone can do what your citizen at the correctional institution did and look up, you're telling me I'm positive. What was the cycle threshold? And to be able to say, like, this is high. Are you sure I have to lose 2 weeks of school, 2 weeks of university, 2 weeks of work, et cetera, et cetera? Or even this is high, or isn't it time to open up now? So I just wanted to say that.
Or conversely, Naomi,
Yeah.
I don't seem to have any symptoms, but let's say, okay, so I want to segue right to what India does with this information. So, and by the way, and Governor DeSantis in Florida, which shows you how even a governor can't control this. He actually issued an order back, I think in early December, that all results because everything has to be reported to the departments of health in the states. Right. So all results where PCR was done had to include the cycle threshold. They still haven't put anything up at the Florida Department of Health website. That was in December. So, but in India, in India, and again, India is a sprawling country, and very developed, very undeveloped in parts, and I don't know how fully representative this was, but I remember reading lay press reports and then seeing at least a couple of studies where Indian pulmonologists, Indian primary care practitioners were encouraging labs not only to provide the CT to them, but to the individual patients in India. Yes. A number of labs had agreed to do this, and then moreover, at least in the lay press, they were describing how in a country, again, with 1.4 billion people, where you really have to husband resources, they came up with some simple strategies that I don't know how widely they are used, but these are how they were articulated. Was that if you were, say, 50 and had any sort of comorbidity, and even if you're feeling okay, and you tested positive at a cycle threshold less than 20, they actually wanted you to come in for observation at least. Right. If it was between 20 and 25 in that same stratum of people, then you would be in touch with the equivalent of a nurse practitioner, and just to make sure your condition didn't deteriorate clinically, and then regardless, when you're clinically deteriorating, they bring you in. Right. Above 25, they just sort of blew it off. And then a study actually came out from I think it was southern India, where they actually used real data on the cycle thresholds in terms of transmission, in terms of COVID-19 transmission. Right. And what they found was that basically it was confined, transmission was confined to super spreaders who coincidentally had cycle thresholds less than 20. And that
Wow.
there was very limited transmission across the spectrum, and certainly there was basically none in that above 25 or so.
It's such a smart, obvious, sensible thing to,
Yeah.
and India's doing well. I mean, and they can't distance, and a lot of people can't mask, and
Well,
they're doing well.
yeah, and the other thing it says is that, you know, without even getting into the debate whether we should have done this sort of mass testing, you know,
Right.
period, which is a new paradigm which has not been used before for this type of illness. But
Right.
but regardless, the genie's out of the bottle. I mean, it's being done. It makes it worse to just discard or conceal this information. It's there. It's there.
There it's and also I would say something else legally. It belongs to the public. I mean, even if it's a private company harvesting your data, from the PCR test, and I read the terms and conditions carefully, and they do say you're giving up medical privacy. Google gets to own your PCR test data. Once it's reported to the public health government agencies, it belongs to us. It belongs to the people of Rhode Island, the people of Massachusetts. That data belongs to us, and they have no right to withhold it. So
you would be able to comment on this, but do you know what we were told? And even after we eventually published the data, the argument was, and you can go to the CDC website and see. No, it wasn't privacy. It wasn't privacy. It was worse. The argument was that it's a qualitative test. It's not a quantitative test. Wait. And I'm like, it's a qualitative test. Then why arbitrarily set the cycle thresholds at 40? Why not 20? Why not 25? Why not 30? You're making a decision, on top of which we know how the platforms work, where literally there's a signal when it becomes positive, and that signal corresponds to a certain number of cycles that it's going through. So that is the.
And Dr. Bostom, explain to lay people the difference between a qualitative and a quantitative test, please.
Yeah, so qualitative means that it doesn't matter where it became positive in this case, it's just positive. And that's all we're giving you, and you can go, screw yourself. You're not going to get anything else out of us. And quantitative would say, well, look, this is the nature of the test itself. It goes through a certain number of amplifications until the test becomes positive, and that information is typically stored directly in the computer system, or again, like I described, maybe on a little printout, but it's always there. And that's how, after all, Naomi, how would they know it became positive anywhere before 40? It's
ridiculous for even having.
Ridiculous.
Because I just compare the PCR test process to every other medical test I've ever had in my life, and even every interaction with government or private industry I've ever had in my life. There's a detailed, when you get a mammogram, when you get a sonogram, when you get an MRI, you get this detailed printout. What was it? Where did it happen? What were the results? And these are important for many reasons, including, if you ever need to take legal action, to be part of your medical record. And the PCR test vanishes into the air, right? Vanishes, right?
Very. So for example, the clinical specialty that sort of that my career boiled down to was I had run cardiac rehab programs, but when I was just so consumed with the research that I was doing, I was literally just running what was called a specialty lipid clinic, people with cholesterol disorders. So sure, we ran a total cholesterol, but it would be like me saying, when we had all these tests and the supportive evidence to say, well, your cholesterol is high.
Right.
And like, well, what do you mean, doc? You did this whole profile on me, what were the subfractions, et cetera, et cetera. Oh, no, don't worry about that. Your cholesterol is high. You have to do X, Y, Z.
Unbelievable. And then going on to say, we have to, strip assembly from a whole state, because we've tested their cholesterol. They're going to fall over with heart attacks. Just trust us.
Exactly. It's just, I never heard of this, So and then it turns out that there's actually a body of literature to show that this is very clinically useful. We were interested in terms of a state population, but there are a number of papers now to show that actually the viral load is of prognostic value at the worst end of the spectrum of the disease. People that are admitted to the hospital.
Right.
So it's all useful. It's all useful.
You're saying something much more serious than it's all useful, because if you don't make public and tease out the high viral loads, the low viral loads, high cycle thresholds, low cycle thresholds, you're putting people at risk. It's really malpractice. I mean, it's medical malpractice, because people who need to be watched and monitored the way they do in India are not being watched and monitored.
Well, and think of college campuses.
Right.
I have two kids, at a major state, I won't name it, but at a major state university, and they're subjected, to this testing and random testing and things like that. And I actually wound up analyzing as best I could using lay reports, using data dashboards. I think I got to 140,000 positive tests on campus right before the Thanksgiving break. So that was really the bulk of the fall semester, starting in the summer. Out of that 140,000 positive tests, I could only identify 15 hospitalizations. When I drilled down into the hospitalizations themselves, most of them were for rehydration. Kids that had spiked very high fevers, the kind of care you could get in an emergency room. Maybe 8 hours of observation. There were some serious cases, but these were particularly, morbidly obese kids with asthma, who had some very serious hospitalizations. But that was a group of 15 out of 140,000, and there were no deaths in that group. And so I was trying to convince, the student health director where my two kids go to school. Look, let's do it as a study. Let's see how the cycle thresholds predict even symptoms and things like that. And it turns out there was a platform at MIT Harvard that had a contract to about 110 Northeastern universities. They have all the cycle threshold data. They've actually published them for the state of Massachusetts, not from the campuses, but from a study of about 35,000 nursing home residents and staff. And it was a very interesting preprint. What they found, Naomi, was I believe the cut point was 26. They extrapolated to the total viral load of this population of about 35,000. And what they found was that 99.99% of the total population viral load was confined to those who tested positive at a cycle threshold of 26 or lower. So we know all these things. The data are out there. There are there. Again, you go from 35,000 to the individual. Sure, there's going to be variation. But the data are there. It's the same platform that's doing all this testing on kids in college, and all the So imagine.
That makes me furious.
There was one study at the University of Colorado which actually showed. I don't know if they used this clinically, but it was a research study that again published as a preprint, which basically showed, and I think their cut point was more like 28, that it was the kids who tested below 28 who were basically capable of infecting other kids. Kids above that were not capable.
And everyone else is fine, but they're locked in their rooms, they're quarantined, they're made to, wear masks all day long. They're treated like prisoners, and they're losing.
They're all lumped together. There's no discrimination, even though they have the data to discriminate, upon.
This is a violation on so many levels. Those parents who are paying, $10, $20, $30, $40,000 a year to educate their kids, and their kids are being subject to not unnecessary testing, but almost like harmfully, deliberately misused testing. Should have a cause of action.
If you want to have sort of a cynical laugh, you could go back and read H1N1, which is more deadly. It's certainly more deadly in the pediatric population. It's probably somewhat more deadly, through the college years in terms of real morbidity, mortality than SARS-CoV-2 has turned out to be. You look at the guidelines. These were very rational guidelines during the Obama administration by the public health officials. For college campuses, they recommended that if there was going to be any testing at all, it would be people with a clinical illness, kids on college campuses with a clinical illness.
Yeah.
And as far as masking went,
Right.
they said that the only persons who should mask are those that were clinically ill to prevent, to potentially, possibly prevent the spread. Obviously, there were already studies to show that that really didn't work, but be that as it may,
but they weren't saying
the masking,
limit
the masking to them. And then they said, particularly if there's just things you have to do that you can't lock yourself in the dorm, then put the mask on and go do them.
Right.
Like if you don't have any laundry left, put the mask on and go down to the laundromat in your dormitory and try not to mingle with people.
Right.
That was the advice for SARS-CoV. For H1N1.
Deadlier disease. Well, look, Dr. Bostom.
In that age range, deadlier. Yes, in that age.
Sorry that we've run out of time today. I want to circle back in a follow-up to talk about baseball. But
baseball at Brown, yes.
Covered so many urgently important subjects. You've explained them so well. I'm gonna really press for state by state and federal legislation to make these cycle thresholds publicly available. This data belongs to us, as I said, and you've done such a public service in bringing your expertise and wisdom to elucidate these things that affect us all. Thank you so much, Dr. Bostom of Brown.
My pleasure, Naomi.
Have a great day.
Take care. Bye-bye.